Well, good afternoon, Dr. Donna Christensen. How are
Good
you?
afternoon. Good Wednesday afternoon. I hope
Yes, yes,
everything's
it's
going
Wednesday
well.
afternoon. You got to check on that because we've had
Yeah.
a very busy week. And here in the DMV, we had a major tornado come through, something I haven't
Yes. Yes. Well, I'm
experienced.
glad your power's back on.
We are
You had a little
yeah,
taste of the Virgin Islands.
we could not bring, compared to the Virgin Islands. Well, we wish you were all there in the beautiful Virgin Islands. So,
Yeah.
welcome
Power
everyone to
outages
our
are.
Wednesday program, Health, Wellness, and Lifestyle with Linda Dorman and Dr. Donna Christensen here on our TV network, Amazon Fire Stick, Android, Apple, Roku, and Tempo Television. And we also broadcast by radio WSTX out of the U.S. Virgin Islands. And I'm here with Dr. Donna Christensen and our wonderful guest that we'll bring up in just a minute to talk about health technology and today's impact on things such as health disparities, blockchain technologies, how we can serve underserved communities more effectively utilizing technology in healthcare. So we welcome to the program our guests. And we have right now a terrific individual. Let me just say this. Kudos to you right off the bat, Mr.
Yes.
Beline, correct? Am I pronouncing that correctly?
It's close enough. It's Luis Belen.
Louis
He and
Beline.
I have worked together for a long time, even before I left Congress. So I've been following him and working with him on in NHIT for years, and he's been doing a wonderful job, not only in DC but in Puerto Rico, the Virgin Islands, and other places as well.
Well, we
And
commend your
hopefully we'll
work.
be joined by Chris shortly. I guess he got tied up in another meeting, but he should be joining us shortly.
Yes, so we have Dr. Chris Gibbons, who's with the Greystone, CEO of Greystone Group Incorporated, and very, very busy as well as a member of the board of directors. And so we're just going to hop right into the
Go
conversation
right ahead.
and talk with you a little bit about. First, we want to kind of ground our audience in understanding some of the work that you have been accomplishing out here. And you are the founder of the National Health IT or Information Technology Collaborative that serves the underserved, for the underserved. That's the official name. Can you tell us about the organization? Because every syllable of that title of that organization inspires me. And I am looking forward to hearing more about it. And so, should our audience to understand how we might look at national health in this way, Information Technology Consortium for the underserved. So, can you tell us a little bit about that? For the,
Well, first of all, thank you and Dr. Christensen for having me, and Chris on the call. Let me clarify that the National Health IT Collaborative was launched in June 8th, 2008.
okay.
And it was actually a joint effort between the Office of Minority Health at HHS, the National Institute of Minority Health, of health disparities at NIH. Uh, there was also about 100 different organizations that were involved in the launch of NHIT. So although I had the amazing opportunity, and I have the amazing opportunity to have been leading the organization over the last 8 years, the reality is that NHIT was launched almost as a community effort to
Mhm.
ensure what our mission is, to ensure that underserved communities are benefiting from the promise of health information technology to address health disparities.
Yes.
And we focus on our five key pillars: uh, workforce, innovation, policy, research, and community. Throughout the years over the last decade, our organization NHIT has been committed to health equity. We have worked with national leaders from the White House to Congress to the leadership in the U.S. Virgin Islands, from uh, former Congresswoman Donna Christensen to the current Congresswoman Plaskett, to the current administration. So we've had a long-term relationship with the Virgin Islands. I am myself from Puerto Rico. And so some of the things that we're so proud of from NHIT is not just doing early on adoption of electronic health records during the HITECH Act and leading national projects and doing White House briefings. But in 2019, we held a congressional briefing along with Congresswoman Plaskett and Congresswoman Jennifer Gonzalez Colon, who helped us convene a congressional briefing focused on disaster preparedness, building innovative national response networks in underserved communities, and looking at building a 21st century health and healthcare infrastructure for both Puerto Rico, the Virgin Islands, and underserved and rural communities nationwide. And we looked at lessons learned from California to Texas to Florida, Puerto Rico, and the Virgin Islands. So NHIT has been looking at not just being a convener during our summits and our briefings, but also what do we do on the ground to really make a difference in our underserved communities.
That this is so commendable, because I'm not sure that we have a real broad understanding in mainstream, and perhaps even in healthcare, what information technology is and informatics, and how that does support driving policy and support resource allocation to different parts of the underserved community to address the health disparities and the social determinants and reducing the incidences of these various issues like workforce, the very first pillar. Oh, look, we have welcome to the program, Dr. Gibbons. Welcome. Welcome.
Hi, how are you doing? Sorry I'm late.
No, that's okay. We're glad to have you, because this conversation is timely and very, very critical. So we were just getting a real strong briefing on the organization and what it aspires to do. And one of the things that I want to touch upon is making sure that our audience is well briefed on what is information technology in healthcare, informatics. And you mentioned health disparities and you mentioned social determinants. We've talked quite a bit on this program about both of those topics uniquely.
Great.
Dr. Christensen, you are on mute.
Yeah. Chris, maybe now that you're here and if you're ready, maybe you could talk a little bit about yourself. You've been working with NHIT for a long time. You've been in this space probably longer than that. And tell us about yourself and how you got into this kind of work and how you started working with NHIT. So as an introduction.
Sure, happy to do it. Thank you for having me. I apologize on another call with a hospital system that ran long, so that's why I'm late. I apologize. But I'm Chris Gibbons. I'm a physician by training. Early on, many years ago, trained in surgery and preventive medicine. But for a whole number of reasons, early in my career, this is a long time ago, before technology was what it is now today, began thinking about, could technology in many forms, whether it's IT or data or anything, but could technology help us improve health? But not only improve health, could it help us actually improve the health of underserved populations specifically? And the reason I was thinking about that is because, let's face it, the problems of the underserved are not new. They're not new in this country. They're not new in other countries. And this country, like other countries, has spent a lot of time and effort trying to fix them and have not done a good job at a national level. So, I'm one of those people that said, why should I do what everybody else is doing and think that I'm going to get a different result, right? So if I do what they're doing, I'm probably going to get the result that they got. So early on in my career, I began saying, okay, I want to be a part of fixing this problem for the underserved. I know what other people have done that hasn't worked, so I'm not going to do that. I'm not going to do that and think I'm different, but what am I going to do? And then when this idea of technology first came to me, back then it wasn't even called technology, it was called e-health. I had never heard of that before. But I said, you know what, this has some promise here. And I began to see some things. I said, if we can get this to work, it might even enable us to do some things that we now consider are impossible to do among underserved populations. And so this is more than 20 years ago, began exploring these things in depth. At that time, there wasn't anybody else doing it. I was kind of all by myself. I got criticized for it. My bosses at the hospital told me, Chris, you need to let this technology thing go. It's not going anywhere in healthcare. But obviously things changed under their feet. And, it's led to a lot of opportunities. And then several years, about 2008, I believe it was, I forgot how I actually got in touch the first time. Maybe you remember, Luis, with the founders of NHIT, but began working with NHIT and helped them to champion this cause. They were always championing the causes of underserved populations through policy and data and things like that, and helping to, at the time, you had a lot of insurance companies and you had a lot of others saying, well, we want to focus on underserved populations, but HIPAA, that thing keeps us, we can't collect the data. And, one of the very, very important things that the NHIT did early on is they actually did an analysis. Maybe Luis already talked about this, but
No, he hasn't yet. We'll let him.
They did an analysis of the laws and regulations that were out there relating to healthcare, capturing data and that kind of thing. And they found not only do the laws and HIPAA laws they don't say you can't get race and ethnicity data. There were many laws that say, in fact, you should collect that data. And that was such a game changer back then, because it was just a prevailing notion that we can't do this. People are going through jumping through all kinds of hoops trying to do it, and you don't need to do that. And NHIT is really maintained. It's one of the reasons I've stuck with working with them, this idea of, just because everybody says it's the way it is, doesn't mean that may not even be true. And it certainly may not have to be that way. And we've sort of tried to challenge this whole notion, and technology became another way to challenge the notion. People said, oh, you can't, some populations are hard to reach, or you just can't do that with this. Well, you know what? Technology pretty much gets rid of all of those things. We'll talk more about that later. And so here we are many, many years later. But that's a little bit about me and how I got started in this.
So, Luis, health information technology is kind of a vague thing. Can you kind of explain what comes under that?
Yeah, it was so interesting. Dr. Christensen, it's like right here, I have the report that NHIT founder, Ruth Perot, put together. And this report was in 2001. Literally, it was issued the same week that September 11 happened. And the name of the report is Racial, Ethnic, and Primary Language Data Collection in the Healthcare System and Assessment of Federal Policies and Practices. That led to the establishment of NHIT in 2008. So NHIT and the community has been involved for a pretty long time in this issue. Let me step back, and I'll promise I'll answer your question, but let me step back. Back in 1985, Secretary Heckler issued a report on disparities. And I bring that up because we're now into the 35th year plus, right? That health disparities has been researched. We know what are the issues. We know what are the concerns, both in the African Americans, the Latino communities, the Asian communities, right? We know what are the disparities. Health information technology and data collection allows us to really understand where are those disparities located.
Yes.
Who is being impacted the most by these disparities.
And how they interconnect.
And how they're interconnected.
Absolutely.
And includes social determinants of health.
Mm-hmm.
So whereas before we just depended on research reports with data that was 5, 7, 8 years, sometimes 10 years old, now we have data, almost real-time data, that allows us to pinpoint where are these disparities. And most importantly, we're now able to layer those data on top of each other, looking at transportation, economics, food insecurities, right? You name it, and we're able to see the data and see the communities that are most adverse impacted. So from a health information technology, you could look at in several areas. You could look at the electronic health record, the health information exchanges, and the data that goes into those primary care systems. And then you have the other data, the data that are not in those records but should be. and should be collected. And those are data that impact our health on a daily basis, right? And how those are adversely impacting our communities, our most vulnerable communities. So NHIT has been in that crossroad. And how do we advocate for the collection of data? How do we use data? And now that we're a rich data-driven society, now we're start looking at what do you do with that data to actually really change and impact the lives of our most vulnerable communities. How do you leverage to make sure that communities have the right resources? And we could get into how we even leverage this whole infrastructure bill that the Biden administration and Congress has passed around broadband expansion and some of the workforce development that I believe are a game changer and once in a lifetime opportunity to address health disparities.
And do you think
I
that
can just add one thing
Yeah.
about that report that Luis just brought up? That 1985 report's known as the Heckler Report now. That represents the first time, 1985, that the federal government in this country at a national level admitted that disparities were in existence. Before that, we said there were none in this country. We just refused as a country to admit they were here. But the year before that, the Secretary's report on health, which comes out every year, came out. And the first time in that, they looked at blacks and it's like, oh, there's differences here. And so that it made them do a special report, which came out in 1985, which was on black and minority health. And there they have this as the data show. So that was a very important report.
And we've had lots of those kinds of reports at the local level here in my community. It's a community assessment need, and the collaborative of all the hospital systems. I used to work for University of Maryland Medical System as an executive, and so we would work with all of our hospital companions or colleagues to bring about that health literacy, that information that we could put into a digestible format for patient competence and even physician competence and service and caseworker provider competencies, given a lot of what we experienced here in the state of Maryland in terms of rate pay and the like. And, you know, kind of stepping back even again, and not too far back, I just wonder, speaking of patient digital health literacy, I had a chance to read the Underfunded Infrastructure Program, The Impact of Health Equity, that Dr. Donna Christensen was the lead author of. Can you talk to us a little bit about the impact of COVID-19 on the pluses and the minus? We had some gains because of telehealth technology, but we still have some minuses because of the digital divide in certain underserved communities. And that's what you're talking about in terms of infrastructure in the digital community.
Yeah, sure. Happy to. I'll say a few comments. I'm sure Luis can add to it as well. But you're right. You know, COVID exposed. I'll say it this way: COVID exposed some things, because one of the points that I made talking to people, I said, you know, what technological advance happened over the last 3 years during COVID that allowed us to use technology? And the answer is, well, COVID happened. I said, yeah, no, that's a disease. What's the technological advance? And they can't come up with an answer. And the truth is, there have been no technological advances. All of the technology that we have been using to connect with patients during COVID was available before COVID. And we could have been going in this direction, and we could have been better prepared, and our hospitals didn't have to be overwhelmed, but the healthcare system resisted it entirely until COVID came along. And it was the thing that saved the healthcare system, right? Because we couldn't go to the hospitals. And so it became a good thing. It opened the minds of many in the healthcare systems. Oh, wow, we can deliver services across digital connections, and it can be done, you know, through Zoom and whatever else. But at the same time, it also highlighted that many people from underserved populations don't have the tools they need to get that service, even when the hospital finally and the doctors want to do it. If you don't have a tablet, or you don't have a phone, or even if you have those things but you don't have a broadband connection, you can't get the care. And many hospitals were forced to realize that now, even though they wanted to give the care, a good proportion of their patients were not able to get it during COVID, exposing the problems and thankfully helping to lead to the infrastructure bill that Luis was talking about a minute ago.
Quite critical.
You want to
Luis?
elaborate, Luis?
Yes.
Yeah, so the reason why Dr. Christensen led that white paper is because we wanted to highlight the need that if we use this infrastructure bill dollars correctly, we could address some of these shortcomings that Chris is talking about. But the reality is that what COVID did, like Chris said, is although telehealth was available, our communities were not adopting because they didn't have
Not
access,
even the providers.
or
Right.
the providers.
Both.
But on the community side, there was concerns not only having access to the to Wi-Fi and broadband access, but then also there was also concern about trust, right? So these are things that are important for us to keep in mind. And this, when you think of underserved communities, there's two parts. There's the parts that we're trying to highlight in the white paper that, hey, lack of infrastructure it impacts health equity, right? But then there's also the trust and the access component. The trust part is when an individual have access to telehealth, are they in a safe environment or an environment where they could actually have a conversation with their provider, right? And that's also part of this whole conversation that we cannot overlook.
Yeah, that's actually important on multiple levels. One, do you trust the provider that's going to be on the other end and what's going to happen with the data that's sent? But actually, the other thing that we've learned too, which is equally important, some patients, when they're at home, might be in environments where they don't want to talk about what needs to be talked about and other people in the house potentially hearing it. And they may not have a place that they can go to be by themselves. And so these are some things that we have to think about in terms of helping all patients, particularly those from underserved populations, to be able to benefit from what these technologies have to offer.
You know, I feel one of the reasons that I was willing to get involved in that paper was I was on Energy and Commerce when we passed the American Recovery and Reinvestment Act. And that was supposed to ensure, well, it was supposed to map out the areas where there was no broadband, not enough broadband, or where broadband was there. And that was supposed to fix it. And obviously it did not. Right. And so we really have to mount a lot of advocacy, I think, to ensure that the same thing doesn't happen again. Right. But that the amount of broadband that is needed reaches every community, especially those that are underserved and need more attention.
You know, Donna, that's a critical point. And we have also come to learn, and Luis and I have talked about it, I think maybe you and I have also talked about it. Technology offers us, digital technologies, tremendous opportunities, I personally believe, I know you guys believe, to help us address and improve and eliminate potentially health inequities.
Yes.
It's also a double-edged sword, because if we as a nation don't do it right, then, and only some communities can benefit, or some benefit more than others, then technology will only make disparities worse, and probably far worse than they ever would have been, because the gaps will get bigger and bigger. So that's also the other reason to look at it. It's not just about, just get it out there. We got to do this right. We have to get the broadband to all the communities that need it. We have to think about, okay, are there problems beyond just the broadband that we have to think about, like privacy in the home, and how do we deal with that? Or, maybe it's something as simple as headphones. I don't know, but there are a number of ways. But
let's talk about that. Let's talk about some of those solutions, because that alone is, I mean, this subject is so broad. We could have, a 3 or 4 hour conversation. I'm sure you've had amazing forums. I'm looking forward to getting more, but we're going to take a quick break for the station and come back to the health, wellness, and lifestyle with Linda Dorman and Dr. Donna Christensen and our wonderful guest, Louise Berlin, as well as Dr. Chris Gibbons. We'll be right back.
This is the Bloomberg Real Estate Report. I'm Denise Pellegrini. If you're looking to buy a new home in and around Los Angeles, there might be more deals and incentives out there than you think.
There's more inventory. If you're looking to go buy a home, people are super responsive. You have options. You don't necessarily have to, offer way above listing price.
Scott Wild is Senior Vice President at John Burns Real Estate Consulting. He says builders are even offering breaks on mortgage rates.
We're seeing people offer mortgage rate buydowns to get that rate from where it was previously to make it somewhat more palatable. If somebody comes in and says, they're expecting rates to be in the mid 5s or up to 6 or something like that, and a builder says, hey, well, there's a way we can solve that problem for you, make it a whole percentage point lower than that for a period of time, because that's the number one thing on most buyers' concern list is I'm buying at a really high rate.
And Wild says the market appears to be softening in Los Angeles, but staying stronger in San Diego. And that's the Bloomberg Real Estate Report. I'm
Next year I went back, I ended up winning and became I got the Marvin Sims Award, which is like the best diverse actor. And they called my name, and as I walked to the stage, white kids was throwing books at me. Real talk, right off the top of the balcony, like, because this black boy won. And then finally, one day I was just cooking in the kitchen, and she was like, Mommy, so-and-so touched me on my private parts like this, And it was that moment where, I had that moment where I told my mom, and my mom was the one that shut me down, and I had a choice, to make. I shot back. What? You can't claim self-defense when you got an illegal firearm and you're 16 years old. I remember my brother right here, he was selling, he was doing this, but he got a break. He could have took that money and flipped it. He could have went back, Wagon Wire money, 17th episode. I could flip that.
Even on the out there, I did not flip. He didn't flip the wire, but I went straight. My bad.
I was a single friend for 6.5 years, and I was going through my situationships. Y'all know the situationships, men. Then I found, just for myself, again, oh girl, you still recovering from your childhood. What you about to do with a man right now?
I had an agent, some years after that, tell me that if you don't do nudity, you're not a real actress.
So did they get fired? So
you should have got fired that way.
Everybody's laughing. They're like, oh my God. They go, okay, great. Are you sad? I was like, nah, I'm Puerto Rican, I'm black.
Everybody did that.
We can pick up the sides right now and start going. I know this group that I'm with is about that. We're about that. I'm about the work. You know what I mean?
Chasing Hollywood industry.
So I saw Chasing Hollywood. I was like, yo, we gonna have to change that name and do something because niggas don't own Chase.
I feel like we're living. That's the term that Hollywood uses.
It's not about just today and me and blah, blah, blah. What we are doing is being documented. Our grandkids, our great-great-grandkids can see how we all walk, talk, sound, look in our prime. And, something about that is very beautiful. And I think that is another element that kind of attracted me to it, is that it never dies. You never die through this art form.
Well, welcome back to the Health, Wellness, and Lifestyle with Linda Dorman and Dr. Donna Christensen. We are having an amazing conversation with CEO and board member Louise Belen and Dr. Chris Gibson, CEO of Greystone Group, regarding health technology and how we address health disparities, social determinants, and how to really create a level playing field when we are driving all things related to health equity for all. So I just want to open up this next segment. We ended with the challenge of a problem in the data collection. And one of the areas that is really significant is intergovernmental. We have silos. And I know that even working as an executive within a large healthcare system, that we often have even silos within those healthcare systems who are delivering, similar services and should be collaborating around the region through things like the community assessment reports to reduce health disparities. But let's think about, how is NHIT addressing this particular issue? And it's significant because we have legacy systems that are not talking to each other. We have legacy systems internal. We have paper-driven systems. I've done a number of health disparity studies, and I am still in awe that we are in the dark ages of 1960s of just using paper and Excel spreadsheets to collect, manage, and assess data. You all are doing something formative, and I've had an opportunity to look at the website and encourage others to do so as well. But I don't want to give the thunder away. Can you talk to us about the Data Infusion Center?
The Data Fusion Center was launched last year. The idea behind the Data Fusion Center is to pull together de-identified, aggregated, and publicly available data and tools that allow for a better understanding of social determinants of health. The conditions and the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. So one of the issues that we have is that CDC has open source data, CMS has open source data, the counties has open source, the states have open source data, but those data sets are not centralized, right? If you think of even where the hospital is located or the federally qualified health center is located, where those data sets, or if you want to know, ask specific questions to do research around cancer or diabetes, right? So the Data Fusion Center is a partnership that we did with Amazon Web Services, another company called Tyler Technologies, using their Socrata platform. The Socrata platform has been deployed or is currently deploying over 10,000 clients from healthdata.gov to CMS and other federal, state, local agencies. And what NHIT has done is started to centralize those data sets. So what are we able to do now? We're able to access billions of rows of data. We're able to bring in the hospital's locations from the Homeland Security. We're able to bring in the federally qualified health centers, railroads, and but then you're also able to say, if you want to focus on the farming communities, where are the farms, where are the H2A seasonal migrants, where are, depending on the conversation that you want to have or the research you want to do, where are those data sets, right? And we're able to bring those. So we have relationships and partnerships at Tulane Public Health School, Howard, Stony Brook, and we'll continue bringing on different universities. And the goal here is to put this data in front of professors and their students so they can ask the questions. It's a huge difference having mainstream researchers do research on African American communities or Latino communities versus having a diverse set of group of individuals doing research on their own communities. So that's one aspect of this. The other aspect, in addition to doing research and visualizing that data by doing the layers that I mentioned, you're able to tell those stories and publish those stories in the Data Fusion Center. The next,
you're also able to plan.
Yes.
Exactly, and that's key. That's key because what we're able to do is we have a disaster preparedness index. We're able to look at where are the vulnerable communities and what should you be doing. So from you talk about those environmental scans or those hospital planning, you could do that with the Data Fusion Center. And then there's also, I talk about data for the sake of data is just data. The reality is that we're now able to start looking at how do you deliver services based on the needs of a community proactively, right? So that's, to us, the next phase of the NHIT Data Fusion Center is how do you really start delivering services or at least help others to identify what are the gaps in a community and where they should focus resources.
And I'm just curious to understand why our tax dollars are not supporting our agencies, our NIHs, our HHSs at both federal and state level, our CDCs, our university research in this area, that we go out to the nonprofit community and have something as formative as NHIT be birthed in 2008 to put something together that is as significant and public driven, to create that patient-centered management systems, to create an opportunity for academic research in specific areas, communities, and within groups. What happened, Dr. Khan? Can someone explain that to me? I want to get the most out of my tax dollars, and I'm just sitting here in awe of listening to this and wondering what happened.
If I could just piggyback, Chris, if you're going to answer that, how does that tie into smart cities and communities?
Yeah. So on the first side, I think if you talk to most governments or academics, say, oh, we're doing that kind of research, right? We are doing that. Your tax dollars are supporting that. But that's kind of the problem. Everybody is doing it and nobody is sharing their own data. Everybody keeps their data to themselves. So we have these silos. What the government isn't doing, what the tax dollars are not doing, are saying we must share data. There's really nowhere that says that. And so people don't share data because they're not forced to. And two, they think at some line along the way, I'll be able to make some money off of this data. Let's just be frank about it. And so resources like the Data Fusion Center are just not a lot there. And it's critical because as Donna was suggesting, planning at the congressional level or at the state level, it's done based on what the data shows. So if you have data that's flawed about underserved populations, that's all they got, right? And they're going to make decisions about resource, about money allocation, about things that are going to be flawed, and then the problem just gets perpetuated. The final piece of that is the people who are doing the research, again, the types of people at the academic medical centers and other places generally are not people from underserved populations. So even those who are doing the research, it's like Louis said, it's one thing to have somebody else doing research about you. It's another thing to have people who look like you and understand your culture to do research on the problems you know of. So
can I add to that, Chris, for a second,
Sure.
if I can? So traditionally, right, you have the Office of the National Coordinator, CMS, and others that have spent a lot of time on making sure we have electronic health records. We establish health information exchanges. We establish these systems. The reality is, and the sad part, is that a lot of these companies are in it for monetization, right? And that's fine. We live in a capital society, and that is fine to do. but we got to be honest with each other. The reality is that health equity is now sexy, and everybody is running to health equity, and so it's being hijacked, right?
Yeah.
That's the way I see it. It's being hijacked.
That's
Then
great
the other
word.
reality is that the big companies, they have a business model to resell the data or monetize the data. So at the end of the day, you still got to go back to the trust in the community. So it's from NHIT's perspective, the messenger matters, right? Doing social good and social impact matters, but being honest. So I talk about this about being authentic allies to the communities that you claim that you want to help. So it's not that the federal government has not made investments. It's not that these companies have access to the data. It's just how they're going about doing it. So from our perspective, I agree. I believe that this is why NHIT is doing what NHIT is doing, is that NHIT, which was launched by the federal government, by federal funds, which was brought by a larger community, should continue doing what we do, which is being the trusted, authentic partner of the communities around this and this data, and most importantly, making sure that the data is being used for good for the communities that we claim we're supporting. So listen, I don't want to start trouble here, but the reality is that this is where we're going, and this is what's happening. The reality is that the big companies are in it for profit, and that is fine, but they should be honest about it.
So I think that's a perfect point that I'll follow up and answer Donna's second question about the smart cities and why am I involved with that. Luis is absolutely right. The world as we live in now is all about the dollar, right, and making the money. At least in my personal viewpoint, and I think Donna and Luis and others would eventually agree with me as I explain it. Okay, fine. If you want to do that, I can do that too, right? There is no reason why people from underserved communities shouldn't be able to monetize their own data, start their own companies, and do their own business. It doesn't and do well just like anybody else. The fact of the matter is we have not had a level playing field, right? And that's why they haven't had the opportunities to start businesses. They haven't had an opportunity to learn how to do that. They haven't had the economic, the educational system has been biased. They haven't learned. So, and when we come to health now, how do we tie this all together in health? One level is those are all social determinants of health that impact health. But when we come back to health IT and health, and we're talking about trying to get technology in the hands of underserved populations, one of the things that I found over the last couple of decades is one of the most difficult problems up until now that we've had was not actually getting the technology in their hands. Yeah, that can be hard sometimes, but you can figure that out one way or another. But it's the connectivity, it's the broadband connections that if you don't have that, the technology is just a paperweight. I mean, it just can't do what it needs to do. And that's a problem that over the years I've struggled with many underserved populations that I've had, which has led me to sort of think about, okay, how can we solve this problem? And I stumbled on this idea a few years ago. This idea of smart cities has become popular across the world. So I started studying those things, and I learned a couple of things. One is smart cities all have a few common elements. They all talk about using connectivity for everybody in the city. They all talk about using AI, artificial intelligence, and technology to improve the well-being or quality of life or services for the community. But I noticed two very important things. One is that most of the smart cities community programs were not really smart cities. They were essentially smart rich side of town projects, or smart business district side of town. And there's a ton of money flowing into smart city projects. So I said to myself, okay, well, maybe if we could ride on the backs of this movement and talk about smart cities, but really make them about smart entire cities or smart communities that include underserved communities, then and that guarantees that the broadband or the Wi-Fi is in those communities, then we've solved the hardest part of the puzzle, We've gotten the broadband to those communities under the banner of a smart cities project or a smart communities project. And then we can figure out how to get the tools to them, how to get them online so that they can benefit. And so we have started focusing on this notion of smart cities as one way to bridge the digital divide in broadband connectivity. Now, thankfully, the Biden administration just passed a bill that will also provide a lot of funds to help narrow this gap. But we were thinking about this before that came in place, and already people are saying that probably won't close everything. But I think smart cities is still a prominent way. But it gets better than that, because a minute ago we were talking about they don't have the infrastructure to start businesses. They don't have the infrastructure for good education. But guess what?
It all comes together.
Right, that's right. In the future that we are going into now, guess what? Education is delivered online. Guess what? The jobs of the future are all online. So if you get that infrastructure in place, you've now got the infrastructure for health, for economic opportunity, for education, for jobs, for all of that kind of stuff. Last year, there were 1,500 people in this country reported by the IRS who operated one-person businesses that grossed more than $1 million a year. One-person businesses, they were all online businesses. Why? Our people can do that too? I refuse to believe they can't. But they don't have the infrastructure to do it. So if we have the infrastructure, we don't have to have these job training programs that train people for jobs that don't exist.
Correct.
What have we done then? We now give them the tools, train them how to start their own businesses where they're creating the jobs. Start their own businesses that are online businesses that serve people anywhere in the world, that they start monetizing their own data. Don't get me started. I could talk forever, but I'll stop.
Chris.
Well, the monetizing your own data is an interesting part to me, because I've been very interested in the NFT and blockchain world. And we're going to have you both back on to really do a deep dive in that, because that is a full education for our non-techies out there. But how that level of technology will help with that smart city, with the digital divide, as well as having control and individual opportunities, that if we were to create NFTs, and that's a new movement, I know IBM and many of the other companies are getting involved in, how do I become custodian of my health data and therefore able to sell it individually versus having it go into an EPR system and then it's collected. Those are important as well. And I believe in that strongly. I also believe in monetizing and having some measure of control as well. But we have to have rules and regulations, policies and procedures, legislative, to really help us, particularly given some of the reversals of the Supreme Court that have recently come down. We're taking 5 steps back in many places while we're trying to go 100 steps forward. It's very daunting, and you're doing terrific work through NHIT in order to create that level playing field and do the education so that we can become stronger advocates of health information technology platforms and strategies. What can we do as individuals to support the initiatives of NHIT and just the overall health information technology community?
And, as you get ready to answer that, I think we talked macro in a way, but for the individuals who are saying, well, how does this really help me? If we could get into a little of that, but go ahead and answer that question.
Yeah. And so here's what we do know. We know about 120 million Americans do not have access to broadband. And we do know that broadband is a super determinant, right? Like Chris was saying, it impacts our employment opportunities, our business, our opportunities, and our health, as well, right? Access to health, right? One of the things that when we talk about how can the community benefit, but also help, the reality is that as these funds come down, and you asked Linda about NHIT and the work, the reality is that the funds still go to the big companies, right? Mm-hmm. You got to have access to procurement. You got to have all these requirements. So the small community-based organizations or the small organizations like NHIT, we are amazing and we do God's work as long as we're doing things for free. As long as we're doing things that do not require getting funded, we're doing God's work. The moment we start talking about funding, we're not necessarily qualified, right? And I think that's across the board with different groups in our community. So one of the reasons why we launched this listening sessions around the country is to listen to the communities. And what we continue hearing from the communities is that they're concerned that the funding is not going to get to them, right? It's not going to get to the communities. So we need to make sure that the community is engaged and understand, and are asking their political leaders and community leaders about how is this money going to get to us so that we could have access to broadband, that we could improve our communities. I think that's important. In terms of, Donna, your questions about how did this impact the
individual, because they will be stronger advocates once they know how much this, we talk big picture in terms of health. How does that impact their health? I'm speaking fast because we're running out of time.
Yeah, so I try to put this more from a commercial perspective to the community. The reality is that we're talking about, at the end of the day, community empowerment, economic development for our communities. If we have access, we could get better jobs, we could be better innovators, and at the same time, we talk about NFTs and data, we could drive our own data, have access to our own data. So basically, this is about self-empowerment at the same time. And think about it from access to data wherever you go, being able to share that data with providers or your loved one, your caretaker. All of these things really impact the individual. Chris, you want to add to that?
No, I totally agree. I would say, we tend to think, that maybe, these fields, NFTs and IT, they're not for us. I would say we need to change our own minds on that. Jump in. The internet is great. Most people have at least intermittent access to it. And now you can go to the internet and learn almost anything you want to. So even if you can't go to a school and do this and pay for it, there are courses online absolutely free. You can learn how to code. You can learn about data. You can learn about NFTs. You can learn about all these things. And the more you learn about them, you put yourself in a position that people will pay you for the knowledge you have. That's what it comes down to. Everybody can do that. We've got to help our kids and our adults do that, no matter what age they are, whether they're young or you're older and going into a second career or a new phase. It's all possible. It's a brand new world out there.
Wonderful. This has been an inspiring conversation. I'm hoping that we can hold you to a part 2 and do even another deep dive. We're talking part 2 coming up soon. So we're going to have to figure out a schedule to get you back on, because there's so much information that we need to talk about, in detail, and really educate our community. But let's make sure that we have a way for our listening audience and viewing audience to reach you, to learn, to support financially as donors and collaborators. Luis, can you give us our website?
So it's nhit.org is the link to our website, and there's a lot of information there. Of course, individuals could reach out as well as at Belen, Belen at nhit.org.
Fantastic. Thank you. And Dr. Gibson, we didn't get a chance to talk about Greystone. Can you give us
all right. No, you can always get in touch with me through Luis and through NHIT. So that's all we need to know for now.
Okay, fantastic. Dr. Christensen, this is a fantastic conversation.
Yes, it is. And it does require a follow-up, because there's so much else that we can speak to. I just want the individuals to also understand that this is, when we talk about putting information on internet or getting on the internet, there are protections in there that provide security and ensure that you can trust it.
There she is.
And you will be in charge of your own data.
Yes.
You will be in charge of your own data. So we don't want you to hesitate because you're afraid of getting in a wide internet.
Yeah, we just have to lower the barrier to understanding so that there can be a higher acceptance of how to become your own health data repository. And that's just a great subject right there that we can talk about. I've just got so many in my head, I can go over it. But for right now, we have to end the program for our next segment. Thank you for joining us on the Health, Wellness, and Lifestyle program with Linda Dorman and Dr. Donna Christensen and our guest, Dr. Gibson and Mr. Moline. And we just appreciate you so very much. Catch us on the next Wednesday. And we look forward to seeing you. Have a great afternoon, gentlemen. And Dr.
Thank you for joining us.
Thank you.
Thank you for